एब्डोमिनल टिभी सुरु गर्नुभन्दा पहिले चाहिँ टिभी भन्ने कुरा चाहिँ के हो भन्ने कुरा सबैलाई थाहा हुनु पर्यो। प्राइमेरी फोकाइ भने के हो, सेकेन्डरी फोकाइ भने के हो भन्ने कुरा थाहा पाउनु पर्यो। फर्स्ट थिङ। सेकेन्ड थिङ इज ट्युबरक्लोसिस इज मोर प्रोमिनेन्ट हाम्रो डेभलपिङ कन्ट्रिजमा। ट्युबरक्लोसिस धेरै नै कमन भएको हुनाले चाहिँ यो एब्डोमिनल टिभी चाहिँ तिमीहरूको थ्योरी एक्जाममा पनि लङ क्वेसनमा आउने प्लस प्र्याक्टिकल केसेसहरूमा पनि राख्ने क्वेसन हो। त्यसैले यो टपिक चाहिँ अलिकति तिमीले राम्ररी नै हेर्नुपर्ने हुन्छ है। Let's go onwards. It is the sixth most common type of extrapulmonary tuberculosis. यसको इन्ट्रोडक्सनको बारेमा धेरै कुरा भन्नु परेन, तर यदि एमसीक्यूमा सोध्ने हो भने चाहिँ हाम्रो कन्ट्रीमा चाहिँ इट इज द सिक्स्थ मोस्ट कमन टाइप अफ एक्स्ट्रापल्मोनरी ट्युबरक्लोसिस भनेर याद राख्नु पर्यो है। द टाइप्स, देयर आर टू टाइप्स अफ एब्डोमिनल टिबी, one is intestinal and the other is extra intestinal. यो क्लासिफिकेसन चाहिँ सर्ट क्वेसनमा आउन सक्छ, त्यसैले क्लासिफिकेसन चाहिँ तिमीले थाहा पाउनु पर्ने हो। इट इज टेकन फ्रम सेभिस्टन है, सो यु पिपल शुड नोट दिस क्लासिफिकेसन है त। इन्टेस्टाइनल टिबीमा चाहिँ इट वुड बी अल्सरेटिभ, हाइपरप्लास्टिक र मिक्स टाइप हुन्छ भने एक्स्ट्रा इन्टेस्टाइनलमा डिपेन्डिङ अपन पेरिटोनियम इन्भल्भ भएको हो कि मेजरली इन्भल्भ भएको हो कि सोलिड हो कि जेन्डो युरिन ट्र्याक्टमा इन्फेक्ट भएको हो। यदि पेरिटोनियमतिर गयो भने इट इज बोथ एक्युट र क्रोनिक टाइपको हुन्छ, जसमा इन क्रोनिक असाइटिक टाइप इज कमनेस्ट। त्यो बाहेक द अदर्स आर इन्सिस्टेड टाइप, प्लास्टिक टाइप एन्ड पुरलेन्ट टाइप। इन द मेजेन्ट्री इट कुड बी आइदर क्याल्सिफाइड, एएमएल, सिएमएल or pseudomesenteric cyst. In the solid organs, it would be involving the liver, spleen, appendix or pancreas, whereas in genitourinary, it could be kidney, ovary and urinary bladder. Are you people getting me?
Yes, sir.
Okay. About modes of spread. Modes of spread भनेको the most important thing is direct and indirect type है. Direct spread हुने भनेको adjacent organs बाट हुने हो. That is most commonly from the ingestion. Ingestion भने चाहिँ contaminated food particles with tubercular bacilli छ भने त्यो mode of spread would be ingestion. Whereas if it is of hematogenous type, it is mostly from the tuberculosis of the lungs. Involving the neck lymph nodes, it would be through the lymphatics. Involving the fallopian tube, that is the retrograde spread to involve the peritoneum, and direct spread would be from the adjacent organs. Now the most important is ileocecal TB. यो चाहिँ तिम्रो भाइभा क्वेशन हो है. Why ileocecal tuberculosis is most commonest site भन्ने कुरा सोध्यो भने these are some of the reasons that you need to state. The first thing is it has evident Peyer's patches where the organisms will get more trapped and they will multiply. The second thing is it is the place where there will be stasis, and stasis bhayeपछि bacterial contamination time would be more high. That's why ileocecal TB is the commonest site. The third thing is there is the liquid content in the region with minimal digestive activity. Now the differences. Your difference, it has been asked in short question as well. Eh? What are the differences between the ulcerative and hyperplastic type of the abdominal TB? The first one is ulcerative. The incidence rate is 60%, whereas in hyperplastic the incidence rate is 10% only. Ulcerative would be secondary to tuberculosis, whereas hyperplastic would be the primary GI tuberculosis that may be due to bovine bacilli. In ulcerative, the virulence is more, whereas in hyperplastic, virulence is less. That's why the incidence is less in hyperplastic type. In ulcerative, there is poor body resistance, means it affects the people who have poor body resistance, that is the older people. Whereas hyperplastic, it would affect young people having a good body resistance. The features would be in ulcerative, multiple transverse ulcers will be commonly seen in the ileum, whereas in hyperplastic, the chronic granulomatous lesions will be seen in the ileocecal region. Now the clinical presentation varies. If it is ulcerative type, they will mostly present with diarrhea, bleeding per rectum, loss of appetite and reduced weight. Whereas in hyperplastic type, they will clinically present as the mass in the right iliac fossa. As ulcerative is secondary to tuberculosis, so the chest X-ray, it will show the primary lesion, whereas in hyperplastic, there will be no primary lesion in the chest X-ray. Barium studies, they will show ileal stricture with hypermotility in the ulcerative, whereas in hyperplastic, they will show the pulled up cecum with obtuse ileocecal angle, that is less than 60 degrees. The complications would be in ulcerative, there will be stricture and intestinal obstruction, whereas in hyperplastic there will be subacute intestinal obstruction. यो चार्ट बुझ्यो सबैले? हेलो ओके. In the investigations, we will see first of all the chest X-ray to find out the primary lesions that will be seen in 25% of the cases. Montauk's test, ELISA, ESR. Whereas USG of abdomen, they will show intra-abdominal fluid or ascites, lymphadenopathy, bowel wall thickening, and pseudo-kidney sign. These are the investigations that we will see, and the differentiating characteristics features of the USG are above. If we go for endoscopy, we can find out whether it is ulcer, nodules, stricture, multiple fibrous band, or polypoid lesions are seen or not. The CT features, it will include, there will be thickened bowel wall with thickened peritoneum, adhesions, loculated ascites, enlarged or mated mesenteric lymph nodes, often with the cold abscess. These are the CT scan features of ileocecal TB. This is the diagram, or this is the picture of CT abdomen showing ileocecal TB. अब यहाँ कसरी बुझाउने यो भनेर छाडे त्यसरी गर्नुपर्छ लेट इट बी त्यति पर्दैन होला. Then moving on to ascitic fluid analysis, what would be the finding? The ascitic fluid analysis will show there will be exudative with protein level greater than 3 gram per deciliter, whereas the serum ascitic fluid gradient will be less than 1.1. The glucose will be less than 30 mg per deciliter, and the lymphocyte predominant cells will be greater than 4000 per mm3. This is the ascitic fluid analysis of the ileocecal TB. Now, before moving on to the diagnosis, we'll find out what is the differential diagnosis of all these regions. The first important thing would be Crohn's disease, that is the most common. Then moving on to gastrointestinal malignancy, it could be either sarcoma, amoebiasis, Yersinia infection, or periappendicular abscess. These are some of the differential diagnoses that you need to rule out if you are diagnosing a patient of ileocecal TB. Now the treatment modalities, it varies. It would be medical or the surgical treatment. In medical, the first line drug will be the ATT therapy, that is isoniazid, pyrazinamide, and ethambutol. If there is drug resistant cases, then second line drugs are recommended. The guidelines have been changed, and the recent guidelines recommended regimen is for the intensive phase, it is 2 HRJD plus 4 HR, that is for 6 months. And the continuation phase, it is 2 HRJDS plus 4 HRE for 12 months. Surgery. When will you prefer surgery? The common indications are if the patient presents with intestinal obstruction which is not relieved by conservative management, if the patient presents with severe hemorrhage, if there is acute abdominal presentation, either there is complications of the peritoneal TB, that is intra-abdominal abscess or fistula formation, or if the diagnosis is uncertain and you are sure about the peritonitis. These are the indications for surgery. The surgery are, there will be limited ileocecal resection with 5 cm of margin. That is a therapy of choice for ileocecal tuberculosis. If there is single structure and if there is multiple structure, the treatment modalities are different. In single structure, structuroplasty could be done. But if bowel wall is edematous and friable, then resection would be the ideal choice. If there is multiple strictures, multiple structuroplasty, but resection would be up to 10 cm. And if the structure is greater than 12 cm, or if there is perforation, resection and anastomosis is the treatment of choice. Your surgery is बुझायो सबैले? कि should I repeat again? Hello? Repeat garam?
Yes, sir.
Okay. Indications of surgery followed. Our surgery indication भइसकेपछि गर्ने के त? What you are gonna to do? First of all, the first modality of treatment would be taking the limited ileocecal resection up to where the perforation has occurred. with 5 centimeter margin to be taken for ileocecal TB. But if the ileocecal TB has presented with the stricture, but the stricture is of single type, if there is only a single stricture, then stricturoplasty should be done. But more than in most of the cases, what would be there, if there is stricture, they will present with the edema, so that resection and anastomosis couldn't be done that time. No, then we will take the resection margin more than 5 centimeter, and then only we will do the resection and anastomosis. But in case of multiple stricture, multiple structure plasty would be done. But it is better to do resection and anastomosis rather than doing the multiple structure plasty, that is up to 10 centimeter of the structure. But if the bowel structure is greater than 12 centimeter, that is the preferred technique, or perforation has occurred, then resection and anastomosis is only the treatment left for the ileocecal TB. बुझ्यौ? This is all. अब यसलाई कसैले केही नबुझेको कुरा छ भने मलाई सोध त.